Recording in progress.
Good morning, everyone. We are glad to have you with us for our January Provider Forum, and we are delighted to have StationMD giving us an update and information. So I am going to turn it over to Matthew, and he can give a little intro and introduce our speaker.
Excellent. Thank you very much, Dina. Appreciate everyone's time this morning. As Dina mentioned, my name is Matthew Dardani. I am one of the account executives here with StationMD, and I oversee the Southeast region and specifically Florida. So, I was having a conversation with Jen Radigan of the ARC of Tampa Bay recently, and, it was kind of shocking that we only are partnered currently with one ARC, local ARC chapter in the state of Florida. So she connected me with Dina, and Dina was, gracious enough to highlight this opportunity that we have with you all at this provider forum to get in front and just share the really wonderful service that we have. So appreciative of all of your time. And Dina, thank you for giving us this opportunity. Along with me, Dr. Trivedi, I will let you introduce yourself, but Dr. Trivedi is our Chief Strategy and Growth Officer. So, really excited to let him introduce himself and begin the presentation.
Thanks, Matthew. Can you hear me okay?
Yes.
Okay, great. Yes, just to reiterate what Matthew says, really appreciate your time. We know it's post-holidays, everyone's just getting back into the groove, and just wanted to take this opportunity to talk about what we do at StationMD and how we could work with you to really impact the lives of the individuals that you care for. I'm going to just turn my screen off to just save some bandwidth. But what I'm going to talk about today is really just this, about our telehealth service. I do truly believe it is a game changer for the disability community, and talk a little bit about what services we offer and how we can impact the individuals, but also impact your organization as a whole. Next slide. As Matthew said, my name is Maulik Trivedi. I'm one of the co-founders of StationMD, and our mission is really straightforward, and that is to really improve the quality of life for individuals with IDD, intellectual and developmental disabilities. It is the only community and only individuals that we serve. We founded the organization, myself and several other ER doctors, really was born out of our own experience in the ER, seeing individuals come there, us not really understanding their needs and the needs of the provider community. But also the other aspect of this is that a lot of individuals unfortunately get sent to the ER because there is no other recourse. All of our clinicians, I want to emphasize, go through a specialized training and curriculum that we've developed to understand not just the clinical needs of this population, which are unique, but also the non-clinical. I've said this many times, many doctors before we started didn't even know what a DSP was or what a provider agency was. And that's quite the opposite with our organization. We are in 23 states. We cover close to 50,000 lives now. And we've seen well over 100,000 virtual visits only with people with IDD. So we feel very comfortable with this population. We've probably seen it before. We understand the unique nature, clinical nature of individuals with IDD, but also the unique challenges that provider agencies face regarding transportation and staffing and having no other recourse but to go to the ER urgent care. Next slide. We do take advocacy very seriously. We speak at many conferences around the country. In fact, spoken at the National ARC. These are some of the other organizations that we support because we do really feel that it is our position that we need to be the voice to improve the quality of care for this community. Next slide. So, I'm probably preaching to the choir. Why do individuals with IDD tend to use the ER frequently? It's because outside of their underlying intellectual or developmental disability, they are complex. they have other comorbidities such as behavioral issues or pulmonary issues or GI issues, and they're on multiple medications. And even if they have a primary care doc, we all know that it's not that doctor is immediately available or ready to answer your question. And oftentimes they, say, oh, well, I'm not sure about this. You need to go to the ER. There's an issue of access, getting access to quality, and I emphasize that quality medical care by individuals who understand individuals with IDD is a challenge, not just in Florida, but all over the country. And then lastly, there are a lot of regulations. These are regulations that are well-intentioned, but put a burden, to be honest, on agencies and staff when if someone falls, you have to do this. If someone takes the wrong med, if something transpires and you don't know what to do, you have to fill out multiple forms. And oftentimes we as clinicians can tick that box for you, make sure that, you are able to get seen in a relatively quickly manner so you can address that medical concern. Our goal is really how can we address individuals in the least disruptive, most stable environment. And that, of course, is their home setting, whether it's a group home or their own home, rather than having them send out. Next slide. So, what are the challenges in emergency room? It is a chaotic place. Oftentimes you're in this situation, the person's laying in the hallway. I've always discussed this as the trauma of transport, just getting an individual there. You have to call transportation, arrange transportation. They don't go by themselves. Someone has to go with them, a staff member. And so you have to backfill that. And it's exposure to the individual. Of course, COVID was a bigger issue, but it's disruptive. I put in here missed medications. In my years in the ER, I have had several individuals come just because they needed a med refill. And then again, these are not an hour or two ordeals. These are 8 hours and day or two to recover from. And it's traumatic. Individuals are frightened. You can imagine being laying in the hallway yourself, but imagine now you're nonverbal. You're unable to express your feelings. It is quite a challenging space. Next slide. I just put this in. This was an article years ago about physician attitudes towards people with disabilities. And many of you who are in this community know that they don't feel comfortable caring for this community. Something like 85% of doctors anonymously voice that they don't want to care for people with IDD. And some of that's because they don't get the appropriate training. And some of it's because a largely Medicaid-based population. But I just think it's kind of disheartening. And if this was any other community, poor people or people with heart failure, it would be front page news. But individuals with disability oftentimes are kind of pushed to the side and don't get the care that I think that they deserve. Next slide. So what is the problem? I've touched a little bit. A problem with going to the ER urgent care. Obviously, it takes a while. It's traumatic to the individual. It is very unspecialized care. You go there, the DSP sometimes goes and you're seeing a clinician, ER doc, who is seeing 20, 30 other people. They hand them that binder. I don't know if you guys have used those binders. They're big, like telephone book looking things, and no one reads those, and they end up getting over tested, and it really is poor care. Of course, adding to all that unnecessary testing and hospitalizations, it's expensive. So we feel that for many, many issues and medical concerns, there's a better alternative. Next slide. So if we switch gears to telehealth, and you may use it yourself through your own plan, I would argue the value of telehealth for individuals with IDD is even greater because of some of what I've touched on. Transportation is an issue. Going to someone who really understands, is specialized in this care. Staffing. It's not like the individuals hopping in a car or Uber and going themselves. So because of that, for many issues, we can address the individual in their home. And that is another very big part of this, is many individuals that we care for, taking them out of their home setting and putting them in a car and sitting in a room for 8 hours, it's disruptive and it's challenging, and they're not the same person, as opposed to treating them in their own space where they're comfortable, resolving the issue in 20 to 30 minutes. It's a game changer. Next slide. So how can we help? How can telemedicine help in general? On the left is the problem, the right are the solution, lack of access. So with telehealth and our solution at StationMD, as long as there's a Wi-Fi signal or a cell signal, there are no geographic impediments to where we provide care, or how far you are from a hospital or urgent care, or where you are in the state. The poor care that this population generally receives, again, you'd be connecting with doctors and clinicians who are specialized in this field. We have access to all their medical records. We have our own EHR, electronic health record, so you're not dependent on the DSP or that binder. We know what their meds are when we do the evaluation. We provide full documentation of all of our interactions back to the staff, to the agency. It's written in plain language so the DSP can carry it out. No medical jargon. Of course, we are available 24 hours a day, 7 days a week, so you can contact us for questions or any other issues. And we also send that note to the primary care doc, so they're kept in the loop. All of that documentation is sent to whoever's authorized to receive it, and also kind of, again, ticks that regulatory box if someone fell or took the wrong medication. Next slide. I do want to emphasize that it doesn't have to be an emergent issue. If you have a question, you need a refill, constipation on day 2 can turn into bowel obstruction on day 5 or 6. So we want to be called and we can address it. Behavior changes, UTI turns into urosepsis. So we address all of these. And the one thing that I didn't anticipate years ago when we started was the tremendous support that we are providing with staff. They're already pulled thin with cooking and driving people and being their therapist and giving them their meds. They shouldn't have to be clinical, and oftentimes they are the only line of defense before they have to go to the ER. And now they have another resource in us, and they can call us and ask questions or clarify something, or also just verify that, hey, the person's fine, and they're going to document that they're fine, and we're going to send them that documentation. Next slide. This is just a screenshot of that platform that you would have access to. It's a little hard to see, but we call it Station Connect. It's a client portal. You would see all your individuals. The doctor's notes are in there. You can run reports. Of course, it's HIPAA compliant, and it is everything you'd need to know about your individuals, and you would have access to that via password. Next slide. So lastly, I just want to go through some outcomes. Some of this I can go through quickly in terms of cost savings, but if we go to the next slide, you can see that over 90% of the time when we get a call, we are able to resolve the issue and not send an individual out. Last year, we were at 94%, meaning over 9 out of 10 times, if you call StationMD, we will resolve whatever medical concern you have and not send the person to the ER. The next slide has some of those reasons we get called, and again, it's probably going to be a little hard to read, but they're all things that are probably familiar to you. URI, upper respiratory infection, fall, constipation, cough, pink eye, rash, cellulitis, fever. The light blue are the ones that we keep and we don't send to the ER. The dark blue are the ones that we do have to send out. We can't obviously address everything. But another feature of our services is that anytime we send someone to the emergency department or urgent care, we will call in advance and let them know that, hey, I'm sending Bill from this ARC, and he just needs an ultrasound of his legs. Try not to make him wait in the waiting room forever. He doesn't need blood work. It really does expedite the care. It also allows that individual to come back into the community knowing that someone's going to care for them. They're not reflexively just admitting them. But also is a gold standard from a clinical perspective. I've worked in the ER over 20 years, and when another doctor calls me, it really makes the visit better. I'm not sifting through files and paperwork trying to figure out what's going on, why they're here. It really allows me to have a clearer diagnosis of what and plan of what I want to do and avoid a lot of unnecessary testing. Next slide. Yeah, these next slides we can go through quickly. This is just some cost avoidance. Obviously what we're doing is avoiding ER visits, urgent care, hospitalization. So you can go to the next few slides. It just shows that there's a tremendous cost impact on this. And this was some methodology we had used in Pennsylvania. I think if we go to the next 2 slides, you can go, one more after this. Yeah, one more after this, sorry. So, these are just showing, you're talking in the millions of dollars for a couple thousand individuals that we're saving, the state or Medicaid or whatever payer. But if you go to the next slide, we're also impacting, oh, sorry, one more, Matthew. We're also impacting provider agencies. Oh, this was a satisfaction survey that we did. We actually partnered with an organization to ask individuals themselves with IDD if they were happy, and they were overwhelmingly happy with their visit, and they would recommend it to a family or friend. Next slide. So this was just an agency in Pennsylvania that we partnered with. Outside of the medical costs, we're also saving agencies a lot of money because they're not paying overtime costs. This was an agency, say $82,000 annually. It's a couple hundred people, I think. And then I think the next slide is another agency that showed savings in New York of $30,000 annually. Even in 6 months, there was 174 calls. The point of this is that you are not paying for overtime, not spending time in the ER or urgent care, addressing your medical concerns. Also, the staff was overwhelmingly happy because one of their big pain points and one of their biggest frustrations was not having any clinical support or medical support and feeling like 911 was their only recourse. And as we all know, staff retention and turnover is huge. So it's another way that agencies have employed the use of StationMD. Next slide. Sorry, this is just a QR code. You can also go to our website, stationmd.com, but this shows you just how it works. Real simply, there's no equipment needed. As long as you have, like I said, a cell signal or Wi-Fi. The way the process works is you would dial a toll-free number, and we get a person on the other end that stays with you until you connect with a doctor, get some basic information. We do like to get vital signs. Let's just say someone has a cough. We get the vital signs, they have a cough. On my end, if you can use Zoom, which you're on now, it's a HIPAA-compliant Zoom platform. You press a button on your device, your phone, your pad, and the doctor pops on. I do my evaluation. Let's just say I have to prescribe meds. I can do that. If we do have to order tests, we can do that. And then that note, after it's completed, that visit, we send that off to you. You get it as the agency. The primary care doctor gets it, whoever's authorized. We also have an aftercare nurse, when relevant, will call the next day, say, hey, I see you saw Dr. Trivedi. Did you fill your prescription? How are you feeling? Of course, anytime during this journey, you can always call back because we're on 24/7. But that's an example of something that, in the real world, 7, 8, 9 hours in an ER to just get this taken care of. And this is resolved in 20 minutes. Our average time to connect, I think, is 7 minutes, I believe, to a clinician. So a lot quicker, a lot more impactful to the individual than, going to the ER or urgent care. I do finally, in closing, believe that, in this day and age, there's no reason you should be going to an ER, whether it's StationMD or not, for issues like falls or simple sore throats or med refills. You can call us. It is a better way, a more expeditious way, and of course allows that individual to do what they love rather than spend hours and hours in an ER or urgent care. So I will stop there. I don't have too much more. I think Matthew may have put some information in the chat, but if you have questions, please feel free to reach out. I do want to briefly touch on our behavioral health service that we have, but let me pause there and see if there's any questions in the interim.
Hey, one question in the chat is, what type of insurance do you accept?
Oh, great. Yeah. So the way our solution works is we have a per member per month charge that the agencies are paying us. And correct me if I'm wrong, Matthew, that's $35?
Yes, correct.
Yeah, so $35 a month per person, which covers 24/7, call anytime, no limit, all the documentation. And then we take every insurance. We try to recoup from if it's a eligible claim, but we never charge the agency anymore, and we never charge the individual. There's no copay, but any insurance they have, we will work with them.
Great. So I don't see any other questions in the chat. We can open it up. People can unmute themselves and Okay, so now we've got two others in the chat now. So do you provide PCP? And how do we enroll? Are the
Sure.
two questions.
I will leave the second part to Matthew, but regarding the PCP, we're not their PCP, but I'll say that with an asterisk. We get a lot of primary care calls because they can't get to a PCP. It takes forever. I've been working in an ER, like I said, for a long time, and most of what I see is primary care. People come in because they can't. So we will do a lot of primary care, but technically we are not their PCP of record, but we will work with them if they have one. The other thing I'll say is we do provide, and I do this for several agencies. I am the medical director. So I will serve as kind of the liaison for the agency when it comes to interacting with families. I do education to staff. We go through some of the basic common issues like the Fatal Five. A lot of times hospitals will try to send an individual back to you guys and their doctor will be refusing. So that's another feature that we provide that is a medical director. And we can provide you with some of that information. And then Matthew, if you want to just talk about how you enroll and how you start.
Yeah, yeah, appreciate that. So I actually just put my contact information into the chat. So you'll find that there, my phone as well as my email. In addition, Dina will be sharing out the PowerPoint slides, and the slide deck that she will share has the final slide of the presentation has all of my information on it. If you have any questions, if you want any additional information, if you want another presentation with anyone else in your organization, you can reach out to me. I am happy to meet with you. And then, as Dr. Trivedi said, if you do decide to move forward with our urgent care service, we would have an implementation meeting and review the contract, and then we would take additional steps from there. It's a very straightforward process. I just a couple of things I wanted to just add. I know Dr. Trivedi mentioned our reporting suite, but it is a pretty robust suite that I wanted to just touch on. In addition to that encounter note, that visit note that comes almost in real time to whoever you designate to receive it, that has the assessment, the treatment, the outcome, all of the information. And again, you can sort of assign who you want to receive that information as soon as that clinician signs the note. But in addition to that, we also have a monthly utilization report where, sometimes it's more of the, DONs or the executive directors, where every month it provides you sort of a higher level overview of the count of calls that were received, the outcome of those calls, what facilities or what addresses those calls came from. So it really helps you kind of organize the utilization and the cost savings that you're having month over month. And then lastly, I know there's a couple other questions that came in. Lisa, I see your question. It's $35 per member per month. So, depending on the size of your agency, whoever you want to enroll, that $35 allows them the access to our 24/7 urgent care line. And the other thing I was going to mention is, especially in Florida, one of the other beautiful things, us being licensed to practice and do business in various states, this service travels with the individual. So if you not only within the state of Florida, if they leave their home and they're at work, wherever this individual goes, you can call, it travels with them. And if they leave the state of Florida for a holiday or a trip, any of the other states that we are doing business in, like Georgia, South Carolina, North Carolina, Texas, Tennessee, it also can be utilized in those other states as well, which is a really, really nice feature as well.
And one other question was, what is the average cost per client to the agency? Is that the $35?
Yeah, so we consider that sort of our access fee. So it's $35 per member per month, whoever you're looking to enroll. And one thing that does often happen is I meet either monthly or quarterly with a lot of these, a lot of the partners that we have in the state of Florida. So, sometimes agencies will either, increase the number of individuals they want to enroll. So, month over month, if you have additional individuals, or if, individuals leave your organization and go elsewhere or pass away, we can always adjust that user list, or the individuals that are enrolled. But it is the cost of it, that access fee to reach our clinicians 24/7 is $35 per member per month.
Great. And are you currently recruiting new physicians?
Yeah, I think we always are. We can get you, if you want to send that information to Matthew, and then we could forward it to our chief medical officer. Yeah, absolutely.
Great. And that was from one of our chapter members down in
Okay.
Central Florida. Okay, so we're going to open it up and see if there's any other questions or comments. We appreciate Matthew and Dr. Trivedi taking their time today. We will send out a copy of the presentation as well as Matthew's contact information.
Yeah, Dina, I'll forward it to you and through Matthew. I'll just like a one pager of
Sure,
the services that we provide. So if you have any questions, so
that would be great.
sure.
Okay, well, we are done a little early if no one has any other questions. Again, we appreciate you so much taking time to present. And as soon as I say that, we have another question. So, is there a site component available?
Yeah, I can talk a little bit about that. Matthew can add. I'll say two things. A lot of calls that we get, and again, you guys know this, something like 40% of the individuals that we care for have a co-occurring behavioral health diagnosis. So we get a lot of calls for agitation or someone's acting out, or you guys know. The first and most important thing is let's make sure it's not clinical. I've had many people like, oh, so-and-so's banging their head. Well, they have a toothache, or so-and-so has having a behavior, quote unquote, and they're constipated or they have appendicitis. So all of our docs are trained to handle those behavioral issues outside of a true homicidal or suicidal event. Those obviously need to be addressed outside. That being said, we do have a separate service line, which I'll forward some information about that, where we do scheduled behavioral health visits, where we have our own psychiatrist, psychologist. Getting to a psychiatrist and for our population is extremely challenging. That's not just Florida, that's everywhere. So this service line, it's almost hard for us to keep up with the demand, but we do offer that service, and I can send some collateral on that. I don't know, Matthew, if you've been any. Now that is a separate.
Yeah.
But we
Yeah,
do.
no, I was just going to kind of reiterate what you said is that, what we do, the clinicians do during the urgent care line is they can help to de-escalate certain behavioral health situations if there is sort of increasing anxiety or increasing aggression. Sometimes, oftentimes, an individual may perseverate on wanting to go to the doctor or wanting to go to the hospital, and having that telehealth visit really helps to sort of de-escalate that situation. But as Dr. Trivedi mentioned, we do have that separate telepsychiatric service line where we take over the psychiatric care of your individuals. The first appointment is about 60 minutes, usually a little bit longer because they do a complete reconciliation of all the medication. But then after that, they're 30-minute scheduled monthly visits. And this really came about because a lot of our urgent care clients reached out saying that they just had such a difficult time, either the inconsistency of the appointments or their psychiatrist not having availability. We aim to sort of fill that gap to manage the medications, optimize and phase out unnecessary meds, really try to get that mental stability and overall wellness with these individuals. So that is another service line in Florida. I'm happy to meet with you and discuss that. For this conversation, we just wanted to focus on the urgent care. But that's a great question. And as Dina mentioned, I will share sort of this nice one-page summary, sort of a one-page flyer of both the urgent care. So you have all of that information in front of you in one, neat place, but then also our behavioral health one pager as well. So you can kind of get an overview of that as well.
Great. And then a follow-up to that, how does this work with nonverbal and those with speaking problems?
Yeah, it works in the same way that we work with them in the ER. We work with whoever their caretaker is, the DSP. If they're nonverbal, whoever's speaking for them, whether it's a family member, we can always, even if someone's not on site, we can patch them in. But in the same manner, I would work with someone if they're nonverbal and they came to the ER, whoever their surrogate is. We do always have a language line. If they don't speak English, we can do that. And then we also, for those that that use ASL sign language, we have a component for that as well.
Great. Good information. Okay, so are there any more questions? Oh, yep, here's another one. Okay, so any more questions or comments? Okay, well, again, we appreciate your time so much, and we're very glad everyone could join us, and we'll hope to see those on our February provider forum.
Thank you.
Dina.
Thanks. Bye-bye.